I'm really excited to welcome Emily Aldridge and Meg Frisco from Craig Hospital today. Emily is a recreational therapist on an inpatient spinal cord injury team at Craig Hospital. She graduated from Slippery Rock University of Pennsylvania with a degree in recreational therapy. Prior to working at Craig Hospital, she was an adaptive sports coordinator with Ronald McDonald House Charities of Northern California and completed an internship with the Breckenridge Outdoor Education Center. Emily has been at Craig Hospital for 3 years. Meg is a recreational therapist on an inpatient brain injury team at Craig Hospital. She completed her undergraduate degree from Slippery Rock University with a degree in recreational therapy. She continued her education in Clemson University, where she received her master's degree in recreational therapy as well. She has also completed her CBIS, or Certified Brain Injury Specialist Certificate, as well as becoming a Peace Love Creator, which allows her to implement expressive arts groups. Prior to working at Craig Hospital, she had the opportunity to work at another rehabilitation hospital and residential homes, all with a focus around individuals with brain injuries. Meg has been at Craig Hospital for 4 years.
And just for clarification, I'm Meg, this is Emily, and today we're going to be talking to you guys about what now, so life after an inpatient stay, returning to community settings and recreation.
I think we have separate ones, so we're good. So ideally, we're not going to read through these word for word, but this is kind of our hopes for you today. Hold us to it. A brief overview of Craig. Has anybody heard of Craig Hospital in this room? A couple? Nice, okay. So for those of you who haven't heard of it, we're just in Englewood, a little bit south of Denver. We are a rehab hospital specializing in neurorehabilitation, so brain injury and spinal cord injury primarily. And then we're a nonprofit hospital, so that kind of changes things for funding. But from our perspective as rec therapists, we are not insurance-based or funded by any of that. So our foundation at Craig, which is kind of a separate entity from the hospital, funds all of our programs. So when you're looking at some of the things that we're able to do with our patients, it's not because insurance has said it's medically necessary, but because our foundation is very supportive of us.
Just a little bit more about who we serve. So our patient age range is anywhere from 16 to 75. There are some outliers, of course. A lot of times why we are unable to admit anyone under 16 or 15 is just due to the equipment that we have in the hospital. It's not the appropriate or safe size for them. And then 75 or older, it's really about if they're able to tolerate at least 3 hours of rehab a day. Realistically, at Craig, they're probably getting 6 hours, sometimes more, which is very different than a lot of rehabilitation hospitals. Another big difference is just our length of stay. So average length of stay is 2 to 4 months. And again, there's outliers more or less. A lot of that is just depending on if they're reaching their goals, medical status, and of course, insurance.
And then we'll try to keep these informative slides a little bit brief because we don't, on campuses, you don't need to know every little detail of a medical diagnosis. But so with spinal cord injury, when we're talking about, especially some of the equipment that we just showed you all out there, the general presentation of spinal cord injury, obviously being paralysis of part or most of the body. We have paraplegia, so those are folks that, like Meg was mentioning with the grit chair, that have strength and function in their upper extremities, to keep it really simple. And then tetraplegia affecting all 4 extremities. And the presentation there, like we mentioned a lot with some of our equipment and why we select certain pieces of equipment for certain patients. We see a lot of decreased grip strength, especially with tetraplegia. We have them use functional tenodesis, which if you today just were to rest your wrist and just pull back, you can still grip something even if you can't actually grasp it with your fingers. Poor neck and or trunk control, the ability to kind of hold themselves up and hold posture. Spasms and tone, just kind of an involuntary movement of the body. But if you're thinking on like sports and being on campus, if you're seeing some of these things, it's good to kind of know exactly what is the background of it for somebody, not just that they're moving intentionally. Muscle atrophy, if you can imagine going from being really active to then kind of being seated in a chair for all or most of your day, it's really quick and easy to lose your muscle tone, so we see a lot of that. Poor skin integrity, I kind of touched on it with like the rugby chair out there, but because they're not getting that same kind of circulation, you may also see students completing weight shifts or just moving around, because just like you all are going to be in this presentation, you're going to scoot around a little bit. You're not going to, if you're on an airplane, you're sitting there, you're going to move around. If you're getting uncomfortable in one spot, but someone without sensation can't necessarily do that. So they have to include it into their routine to do a weight shift, and again, be really mindful of their skin integrity. We talk a lot too about like padding and positioning in our recreational equipment. Deconditioning and poor endurance, similar to like the muscle atrophy, just knowing that their body has changed quite a bit after an injury like this. Proprioception deficits, so knowing where you are in space. When they're first learning an adaptive sport, that can be really difficult to try a new piece of equipment and understand exactly how to move it when their body is kind of responding differently than it once did. And then a neurogenic bowel and bladder, really being that after spinal cord injury, most, if not all, patients who've experienced an injury like this lose function of their bowel and bladder. And for us, it's a big thing in recreation, and hopefully that you can kind of think of it too on your own campuses, that if somebody might not be able to access your program because it's right in the middle of when they're supposed to do their bowel program, or right when they're supposed to cath and empty their bladder. And so when we think about like rest breaks, timing of programs, that might be a limiting factor for somebody with a spinal cord injury, just simply being able to access a class or being able to access a recreational program. So I know that's a lot of information, probably more than you need, but if you have other questions on it, we can touch on it later too.
And then just going into presentations of somebody with a brain injury. So brain injury is also described as invisible injury. So a lot of times people don't have a lot of physical presentations after having a brain injury, but you'll notice changes in their cognition, vision, and just general behaviors. So just to dive into those a little bit more. Vision changes, cognitive impairments, so think memory, decision-making, initiation, and just day-to-day activities or socially, they might be lacking. Very similar to some of the stuff on SCI, as well as just that poor proprioception. A lot of people who have experienced a stroke might have hemiparesis, or just a visual impairment that truly doesn't allow them to kind of notice one side of their body. So being really intentional if you're teaching a class or leading some kind of activity, being okay and comfortable asking some of these questions on what they need, what they want to have success, because a lot of stuff from the BI side you might not be able to tell just by looking at them. Communication deficits. So one of the big things that we see is either the difficulty to understand verbal communication or to express it. So there could be, a lot of confusion and miscommunication occurring that you aren't even aware of until your student or peer or somebody is doing things that aren't matching up with the conversation. So if you are noticing those things, maybe just digging a little deeper to see if they're truly grasping and understanding what is being said, taught, or asking them to do things. And then the last thing that I'll kind of touch on is those challenging behaviors. So depending on where the injury to the brain is, you might see personality changes and just like impulsivity and poor judgment. So think of like a gas pedal. A lot of people who have injuries to their frontal lobe of their brain don't have that brake. So they're just going to say and do whatever comes to their mind. And that might not be personality. It just might be as a result of the injury that they've experienced. Go for it. We kind of mentioned this, but just to hone in on what recreational therapy is, I won't read through all of this, but in short, it's the use of recreation and leisure interests to help people reach their overall therapy goals, help them set goals, so return to recreation and leisure, expand on their leisure repertoire, and we really focus on like 5 domains, so the physical, social, emotional, cognitive, and spiritual aspect when we are providing treatment to our patients, both in the hospital but in the community as well.
And on campuses, do your campuses have any rec therapists? Yeah?
I'm a rec therapist.
Love that. Okay, cool. If you don't have them, it's a really great tool to partner in the community. Most like community settings, community rec centers have them. Hospitals have them too. Schools occasionally. So it might be a good like buzzword to search if you're looking to help like a student of yours or an athlete of yours get more involved in their community. then recreational therapy services may be off campus, and just partnering with the community could be helpful too. A little bit more about what we do at Craig, so you're kind of getting an understanding of where we're coming from. Meg and I both work on inpatient teams, so we're treating 12 to 14 people at a time. Initial eval, and then creating goals with them based on their recreation and leisure interests. So sometimes we're working one-on-one with them in the hospital, right next to them at bedside. Other times we're taking them on outings in the community and really getting hands-on experience. We do college campus like tours and visits, so we would, again, kind of love to partner with some of you too. If you have any fun facts and things that you think students or prospective students would like to know from an accessibility standpoint. And then the additional opportunity for our services, we also kind of trade through weekends and evenings. So in their off hours, our patients are still able to access functional skills groups and then other like group outings, ice fishing, kind of more of the adventure style things. Some of the main focuses, Meg kind of touched on some of them. You'll see some crossover between BI and SCI, but in general, from the spinal cord injury perspective, a lot of it initially is adaptive equipment education. You've just become paralyzed, life is over in your head, and so we're trying to kind of give the understanding that you can still be mobile, you can still be active, and here's all the things. You don't know until you know. So having someone to kind of educate you. We don't own every piece of equipment that we educate on either. Some of our sessions are really like watching videos and accessing community partners too. Wheelchair mobility, coming on college campuses, going into museums and other places that they might find themselves, again, in the community, and really digging into some of those skill sets. Complex transfers, who tried to get in and out of that hand cycle? Was it easy? No. So when a patient might be learning to go to and from their wheelchair to their bed, we're also trying to teach them how to apply those skills into really complex equipment so that ideally, if they're getting to a college campus, that they'd be able to access the equipment that you have here. And to kind of transfer those skills. Teaching them about resources for funding, we kind of mentioned that. How can you afford a piece of equipment? Insurance doesn't think that's medically necessary. So we have kind of partners around the community and then our own through Craig to help pay for recreational equipment. Skin integrity education. I'm not going to bore you with another spiel about skin integrity. And then returning to their recreation and leisure. So just trying to give them maybe it's just extra repetitions with a certain activity, and maybe it's just continuing to explore equipment so that they can get back to what they used to do.
And just to kind of add on to that from the BI focus and area, and connecting that to like community and college education and stuff, I think some big takeaways could be just having equipment available on campus, around campus, or if you're unable to have it, knowing resources in the area that you can connect your students with is a big piece, whether it's reaching out to us or NSCD, or there's so many places out here in Colorado that offer these opportunities to either come and bring their equipment to you guys to show or to take classes out there, whatever it may be. So just asking is a really good first step. And then I think like in the classroom, from the BI side, especially like just being aware of how you're presenting, that overstimulation piece is a really big thing that tends to be long-term for somebody who has had a brain injury. So if you think of giving a presentation, maybe only sticking to one mode of getting that information out rather than videos and music and all of this other stuff that can just be kind of overwhelming and too much to take in. And then structure is another really big one. So coming from like academic supervisors and other things like that, like really helping them plan out and think out what their schedule is going to be and helping them stick to that structure and routine is so important on both sides, but especially coming from somebody who's had a brain injury.
And Meg and I keep kind of touching on like our community partners, people that we like to work with. We also have like a list of those things that we give to our patients. So if you're wondering, I mean, we could do a whole separate presentation on all those, but if you have questions on specifics on that, please feel free to email us too. Like we said, we left our cards up there so that we can send that information your way too to help you guys out if you need it. Go for it.
Okay. Just to kind of continue on with some of the things that we do inpatient that we hope will help carry out into the community and post rehabilitation stay. It's really empowering and educating, these individuals to drive their own recreation and leisure time in anticipation for life after a hospital and what that's going to look like. So we offer a lot of these opportunities that are not required, but we encourage, we provide the education, we let people come and trial it once or twice to see if it's something they're interested in, if it's appropriate for them, and kind of go from there. If there is a big interest for people, we can help connect them, again, like we've been mentioning, with others in the community that offer these. So really the goal is, not relying on their inpatient therapist and team forever, but being able to be empowered to continue these things outside.
Really brief here too, but just some other resources really kind of focusing on the right side there that we're providing for patients. The National Parks Lifetime Access Pass, does anybody know? Has everyone heard about that? Yeah, so our patients, anybody with a disability can be eligible for that. So if you're working with people on campus, that could be really helpful to just offer them something to help structure their own free time. And it's free of charge if they do it at the national park, or $10 if they want to apply online. And they just need a physician to sign off that their diagnosis is accurate. We keep touching on local and national organizations. We're looking a lot too at like safety precautions, again, skin integrity, overstimulation, just kind of things that we can educate them on so that when they come into a new environment, that they're successful and able to advocate for themselves. Continuum of care, we're giving them our contact info so that when they do get into the next stage of recovery and next stage of life, that we can still kind of be a liaison for them as far as recreation goes. And then adaptive sports organizations too around our state and nationally too if our patients are coming from out of state.
Another big thing is that scholarship information. So we do in-house scholarships, but we're also encouraging and exposing our patients to apply for scholarships elsewhere. So we actually have 2 teen programs within the hospital, one specifically for SCI, which is track, one for BI, which is chill, and they're actually working with a student in the a teacher in the hospital to help them reach those next steps if college is something that they want to pursue, and figuring out what's going to be the most appropriate track for them. Is it starting with one class? Is it morning or afternoon? Are there scholarship opportunities out there based on your disability that you've acquired? So that's another really cool way that we could potentially be tied in with all of you guys.
Some of our outpatient services, this is when we're starting to see people completely leave the hospital. They're back in their home environments, but they're still getting some sort of care from us. So we're doing a lot of community reintegration, continuing to trial adaptive equipment, but in real life settings, not just throughout the hospital. We do our day adventure trips. So some of that is like fishing for a few hours or biking for a few hours. And those are things too that we are partnering with, for example, the National Sports Center for the Disabled, and doing a community cycling program that's focused on Craig patients that day, but that's something that we want to hand our patients off to. So they feel confident because they know us, we take them there, and then we're ideally, after that, kind of done with them at that standpoint, and they can just access that cycling program on their own. So again, if you have some athletes or students on campus that would benefit from things like that, that's not just a Craig-specific resource. That's available kind of to anybody in the community. We also do overnight adventure programs, so we're traveling with people for scuba diving or just sightseeing. We just took a group to Hawaii for surfing, so a lot of programs that we're trying to really extend our arms a little bit and make sure that people, we get patients from Hawaii, we get patients from Alaska, like what can we do and visit them in their home areas to continue recreation outside of us. So just kind of playing off that, each of those trips have 2 of us, 2 rec therapists involved, local, national, international trips. And then they vary on their length of trip and also on the cost. And that's something that someone mentioned it in their earlier presentation, like the cost for something can be a huge limiting factor. Outside of your socioeconomic status, if you have a disability and you're paying all these extra medical bills, you're paying for your bowel and bladder supplies, you're paying for all of these other services, there's not always a whole lot of cash left over to travel. So we encourage people, we work with them to help them kind of create like a savings plan for themselves. We also offer some in-house scholarships to help subsidize the cost of those programs. And with partnering with a community partner, we're usually able to kind of negotiate a lower rate when we explain what our patients are experiencing and all the costs that they have associated with their diagnoses. So advocating for themselves and then us advocating for them is really helpful to kind of decrease the cost.
Just to highlight some of the community partners that Craig works with, but are also available to anybody in the community. And just like Emily mentioned, it's not just local here in Colorado, it's all over the country. So people in New Hampshire, Vermont, Hawaii, Adaptive Adventures has things all over the country. So really having people connect with what is appropriate in their local community is really empowering and really important, and it's something that anyone can be doing. It doesn't have to come from a therapist. So just some of the things to highlight. High Fives Foundation, that is specifically for people who are injured in adventure sports like skiing, snowboarding, mountain biking, things of that nature. Denver Adaptive Divers, and we also partner with A1 Scuba. We do adaptive scuba trips once a year, but we also do tri-scubas throughout the duration of the months. We do an internship program at the Denver Botanic Gardens. What else would you like to highlight?
I think those are kind of the biggest ones too. The little Colorado Sea with the little mountains, that's Community Sailing of Colorado. For cool, they do like family sailing programs too. Have a lot of us seen these before, or some of these new to people? Don't all jump up at once. Any new ones that people have seen on here that you haven't seen before? Lots of new ones? Okay, good.
And this isn't even our entire list. Like Emily mentioned, if you guys are curious about a specific sport or outdoor recreation pursuit, let us know and we might have a contact for them.
And I think sometimes establishing community partnerships seems like a kind of an overwhelming thought, a lot of work, but a lot of these came out of just cold calls. So I guess to empower people to make the cold call and just see who you can talk to, just to be able to establish even a lot of our programs, like our overnight programs, might have started as a one-night trial, and now they're 4-night programs, just to make sure that we're kind of able to manage what the program offers and give our patients a good kind of success rate there. One thing I like to mention too, Meg mentioned the volunteer program at the Botanic Gardens. This is a way for people who can't maybe necessarily return to campus full-time right away or can't work yet. It's a good option for them to just go and still have structure and a sense of purpose. So think about that on your campuses too. If there's something, you have volunteer programs, I'm sure, in a lot of different departments, but if there's something that can be as simple as managing equipment, using some of your students who might have disabilities and aren't able to work yet, or have limited class schedules, that might be able to offer them some structure and a sense of purpose on campus too. If they're not maybe ready to participate in wheelchair basketball, can they still come and help pump a tire or whatever that might be? I think that program and the volunteership has really offered a lot of meaning for people. I'll take it. So just some benefits. I'm not going to read off every single one of these too, but you can kind of get the general idea. It's continued learning, great teaching opportunities for us in the real world, not just in a hospital setting, and really good networking too for our patients, like we said. We don't want them to rely on us forever. As much as we love them, we just don't want to have to be their only resource. So it's really nice for them to meet all the other community partners, kind of like the ones we just showed, and then just continue to develop our program and our growth. A lot of times because of a cold call, and we have one-day program that we have, then we're learning from that community organization what are the things they offer that they don't publicize, or maybe they don't have the resources for their own marketing. So sometimes it's just a face-to-face short program that has offered a wide growth overall.
I think another big thing we've briefly mentioned, but by having these community partners, a lot of volunteers are the ones that are running those groups as well. So it's a really good opportunity for our individuals to advocate for themselves and to practice that self-advocacy outside of the hospital and in the community for people who haven't been working with them for months at a time, just to really see what carryover there is and continue to encourage that empowerment to spread their wings.
Okay, a little bit more of detail, but some things that are helpful to know if you have somebody on campus that has experienced a spinal cord injury. Things that are important for your programming, your recreational programming, and just general access for these individuals. Body mechanics, so for somebody who has a mobility deficit, oftentimes do you guys help transfer people in and out of equipment? Are we like transfer trained too on campus, or do you expect students to do that? Okay. So a big thing for us, we're trying to teach those people before they get into a program the right way to transfer and complex transfers and complex equipment. One thing we see a lot of is volunteers or other students that want to come help somebody and just pick them up and grab them by underneath their armpits and rip up on their shoulders, which we talk a lot about poor shoulder integrity already. And so just simple things that you can kind of help trigger if you see someone else trying to help a student with a mobility disability, just to kind of be mindful of their body mechanics. And ideally, that's something that we're training them already on at Craig. But that's a huge one for us, big safety consideration when they're going out into the community. Transfers, that kind of goes right along with what I just talked about. But winging is one that you can see pretty clearly. If an individual has poor shoulder integrity, poor muscle tone up in their traps and in their shoulders, you can see the scapula wing truly. It's really simple to see if someone actually has that issue. And if you're seeing that in any of your adaptive sports programs, it's not good for them truly. It's only causing more harm than good. And it's a fine line to draw, right? Because you want someone to have a recreational outlet and be healthy and have great mental health and a good kind of active day. But if that is something that's causing more harm than good, you have to be mindful of if they're winging and they're playing 3 hours of wheelchair basketball a week, and then it's affecting them showering on their own, or it might be affecting them transferring into bed and getting to class on time. So just little things to kind of watch out for. And granted, it's not like we're all medical professionals here responsible for these people, but it might just be helpful to trigger somebody and like maybe ask your PT if they're getting PT services off campus, things like that. Skin. It's a huge thing that we talk about. Making sure that your equipment has some decent padding or that you have options for them. Simple things, even just like a towel or a pool noodle can be helpful. Some of that really harsh plastic or metal directly to skin is just not really safe for somebody long term. Padding and positioning goes right along with your kind of skin integrity. Autonomic dysreflexia, has anybody heard of that? Okay, so it's something specific to people with spinal cord injury, and I've got I don't need to explain the whole thing to you, but if you're curious about it, I'd be happy to talk to you about it more. Really, it's just kind of a body's reaction to a stimulus that they can't really feel the way we could. So if you stubbed your toe, this is just a poor example, but if you stub your toe, it sends a message to your brain that says, ow, that hurts. Let me go ice it. Let me go rest it. If it's getting swollen, put it up. But if you stub your toe and you can't feel it, your body still is reacting to that. So it's trying to send a message up to your brain, but because of the level of injury in the spinal cord, there's a poor communication essentially. But the body's still trying to figure out what to do. So it might try to send a message to the brain that says, no, ow, that hurt, but your body says, well, I don't know what you're talking about, sends it right back down, and it just starts this really nasty communication line within the body. And that can look like really a massive headache for somebody. They could be really splotchy, and you're starting to notice that. But essentially, it is, if you look at like symptoms here too, an increase of blood pressure and then a decrease in their heart rate. So that poor communication can be deathly long term if it's not treated. Again, on campus, you're not responsible to treat this for somebody, but it might be helpful if you're seeing somebody in your program that they're getting really splotchy, they're complaining of a big headache. Other like symptoms of it too, they could just get really clammy, kind of sweaty. All of that might be helpful just to cue somebody like, hey, are you feeling okay? It might not be that they're working really hard and that's why they're all red. It could be because of an underlying medical issue. So little things to think about, really simple things to ask somebody just to remind them. The respiratory status is more of an acute thing when they first get to a hospital. Ideally, by the time they're back in the community, they're pretty stable with that. But being mindful of how much you're asking somebody to physically output in a session or in a program that you're running and being mindful of their overall well-being. Temperature regulation. In spinal cord injury, they can't necessarily regulate their temperature the way you and I can. So a lot of people won't really sweat below the level of their injury, which causes just overheating in general. So if they can't sweat, easy things to have on campus and available for them are just little spray bottles, kind of simulate sweat, cool down the skin a little bit. We keep like the bucket coolers that are really simple to purchase at like Home Depot. We have those available for us in the community and just at Craig. Also on the opposite end, once they get cold, it's really hard to get warm again. So just having some layers and options if you're doing outdoor programs and making sure that you have full accessibility for anybody that might just need a little bit of extra equipment or cueing them to bring their own extra equipment. Bladder and catheter management. Again, we kind of talked about that neurogenic bowel and bladder So you may see somebody come in with a leg bag where their urine is draining into, or they might have catheters that they go in every few hours, they go to the bathroom and they empty their bladder with that. So that, we kind of talked about that earlier too, but just having a safe and clean space for somebody to be able to do that. Not just that it's a big enough bathroom, but that is it actually set up for somebody to be able to be cleanly when they're taking care of their own personal care. And then hydration is a pretty obvious one for anybody, but especially in spinal cord injury.
Really quick to touch on temperature regulation. Not only layers, but one big question we get is like, can we use hand warmers? And we really discourage against that because when it gets too hot, they're unable to recognize that. So being mindful of like, don't offer hand warmers or toe warmers if they don't have sensation on that part of their body because it can lead to burns. Thinking of safety considerations on the brain injury side, our biggest concern is always that risk of second injury. You are 3 times more likely to get an injury after your first one. And men, unfortunately, you are at the highest risk of getting a brain injury. But even concussions are considered mild brain injuries. So I know in sports there's a lot of concussion protocols, and that is why they are so important to have in place and to really, make sure you stick to it because multiple concussions we know can lead to long-term effects. And if anyone has a concussion and loses consciousness, definitely making sure that they go get medical help. Seizures are a big thing, so anyone who has experienced a brain injury is at a higher risk of having a seizure as well. Oftentimes, they would be on medications if it's a super high risk, but knowing that that is always a concern. Other things like compensatory strategies for cognition and communication techniques, they can kind of go hand in hand. So like I mentioned earlier, just being mindful of how you're presenting things and communicating, visuals and demonstrations are a really good way to make sure people are kind of understanding what you're trying to get across. We know a lot of people post-injury that use iPads for communication, so thinking in a classroom setting or a community setting, if you see somebody with an iPad, not necessarily assuming that it's just for fun, but that might actually be their communication device. And it does take some practice and patience for how long sometimes people take to communicate using that. Technology is a beautiful thing. A lot of people these days, too, depending on level of injury, both on the brain injury side and SCI side, can also use eye gaze technology to communicate. So if that could be a high-tech device or a low-tech, but I think the biggest thing with that, if you're seeing students or community members that are using these, it's just like slow down, allow time for them to respond, always talking directly to that person, not the person that's with them. You don't ever want to assume that they can't answer for themselves. Time is a big thing. I think on both sides we mentioned this a little bit, but depending on what service you're providing, allowing rest breaks. Sitting in a long, lecture for anyone can be stressful and can get boring, but for somebody with a brain injury, truly just from that attention standpoint, it's going to be really challenging to attend to something for a whole 60 minutes if it's just somebody talking at them. I think that's that.
So some of the barriers to people accessing community and recreation, we kind of talked about that in our previous session too. Like having a cool piece of equipment is awesome, but if you don't really know how to store it or use it or keep it up, that's not really going to be helpful for you long term. But there's bigger barriers as far as just general access to communities. The cost of equipment, for sure. Adaptive equipment is not cheap. I know a lot of you on Campus Rec probably go through grants or ordering of that equipment, and it's not. It's a lot of cash. It's a lot of money. So being able to pay for that is really difficult for people to own their own. So having more than sports chairs on campus could be really helpful if you have more resources or grants for funding, so that somebody isn't having to purchase a separate thing that they're only going to use weekly or just once every month, whatever it might be, because of their personal finances too. We already touched on that. Insurance is a big one for recreation since we don't go through insurance services, so people aren't getting any extra funding from that. Transportation costs and access. From campus perspective, most of your vehicles, like public transit, would be accessible for patients or students, correct? We find a lot in the Denver area that while the transportation system is awesome and pretty accessible, and the cost is actually fine for most people, but the timing is difficult, or they're going to be late to a program. And so just having some extra flexibility with that is really helpful. Location, if you're on campus, for some people it might just be that they're not coming because it's up a hill and they know that by the time they get up that hill they're going to be exhausted and can't participate and won't feel confident. These are things that we find out from patients after communication. So really asking those questions if you're not already about what is it. It's not just that they don't like playing basketball. It could be that there's so many other tiny things. It's hard to get into the front door. The ramp is a little too steep. Family support, the general organizational support. I think all of us are here because we want to support people who need our help. But in general, feeling that sense of safety and support from the community can be a big barrier. Attitude and awareness, just readiness to participate in adaptive sport is hard for people. We talked about the time of your programs. That could be because they're trying to manage personal care and it's off schedule from their normal day-to-day. Their medical needs, taking medications, accessing PT and OT still if it's off campus. Their general confidence and self-image, getting into pieces of equipment that are bulky or make them look a little different. And then media concerns, just to kind of jump down one. We take this really seriously, obviously from a hospital perspective and HIPAA, but thinking about some cool things that you might have some students in, or from us, from a community perspective, we take patients out and get to show them this cool thing for the first time, and if we're taking photos, or their family's taking photos and somebody else is in it, some insurance companies will find pictures like that and say, well, if you can be on a kayak for 2 hours, then why are we paying for 4 hours of therapy a week? And something as simple as that can really screw somebody's kind of benefits up. And you don't want to be doing that from something as simple as just having a good time. So being really, really cautious about getting your clearances from media, really being intentional about where these photos are going or what this video is for, and making sure that you're getting informed decisions from them. Any other barriers that you're experiencing on campus for people outside of this list? Anything you've heard from your own students or athletes? Pretty inclusive list. Okay, great.
I think too, isolation's a really big one. If they're feeling like they're the only one on campus or the only one out of their friends that are going through this, we hear that a lot. So having peer mentorship programs are really helpful. And then just knowledge of resources, both on their end and all of our ends, and providing them with that education and empowerment, like we've mentioned many times. We are spoiled at Craig that we have a lot of this equipment and we can show them, but we even try to be really mindful of what equipment we're showing who, and if it's going to be something feasible for them in the future. We don't want to get someone real jazzed up about something and we're going to be like, this is the only time you can use this ever. Sorry to get your hopes up. So being really intentional as well is helpful.
And then just some really simple things that could be helpful to have either at your rec centers or just generally on campus, things that students might look for to feel safe in a program. This is a purple cushion that Meg's passing around. We encourage a lot of our patients, especially on the spinal cord injury side, to have one of these on them. It's pretty simple to throw in a backpack, kind of folds down, or you can crumple it up a little bit. And this is a great way to offer more padding or safety for their skin in any piece of equipment. So sports court chairs, kayaks, hand cycles, anything that they're going to be trying for the first time, especially if they're not sure how their skin is really going to react to it. It's the same brand as the purple mattresses. So those are a little expensive for what it is, but certainly worth it. You can get them on Amazon. You can get a knockoff brand, but it's worth the investment instead of having to get a skin sore. This is a cooling fan, that black base with the two, thank you, Vanna White. But that's a simple neck cooling fan. You can have them available. They're not that expensive, probably $15 on Amazon, just to have in a drawer at your rec center so somebody can have it while they're playing an adaptive sport and keep themselves cool if they're not able to do that naturally. There's also a cooling rag up there, simple solution for that. We use these really big, I think that is usually used for paint or weed sprayers, yeah. But we fill them with water and have them, they're safe, there's no chemicals in them. To be able to really spray somebody down or have it available so someone can do it themselves, just to have it on hand. And then we have Coban too, this little tape down here, just a reusable sticky tape. Really easy for a quick grip adaptation, Could be something that's just getting them to work out or being able to like hold the brake down on a bike, whatever it might be. Really nice to have on hand. Again, pretty cheap. You can order a mass quantity of that in a big box. We keep it on hand at Craig all the time. Could it also be helpful for people just to get to paint or have a built-up grip to write something down? So having pens available when people have to sign like consent forms or they're signing up for a program. Some people aren't signing up on like in person because they can't access the pen or the writing utensil. So just having some built-up grips could be helpful for that. Slide boards, again, if you're not really in charge of helping somebody transfer, you shouldn't be the one to have to worry about that, but you may see those come in, or could be helpful just to have some on hand to offer somebody for difficult transfers. And then gait belts too, just to have, a lot of people will have those anyways, usually not as much in the community anymore. And that last piece of equipment, has anyone ever heard of a comfort carrier? Sweet, we're learning all sorts of stuff. So the comfort carrier is essentially a sling, but it's a manual sling. So it's got handholds for somebody to actually assist. And this goes, have you seen like videos of people in the hospital? There's like an overhead lift sling that gets them up. Yeah. So it's ideally that, but without an overhead lift. So you could have something like this. And it's got handles. You can do it with 2 people or 3 people. And you just place it underneath that person to help get them out of their chairs safely. So you're not ripping on their shoulders. It kind of makes them into a little like burrito, essentially. So it keeps them really secure. All of their joints are in a good, safe position. And then it's also safe for you or whoever you're training to be able to assist them. And that's also a decent thing for recovery. So if somebody ends up, they fall out of this piece of equipment that you're showing them or that you have available on campus, and you're not sure how to get them up off the ground, this is a really safe and easy way to do that. That piece of equipment is a little bit more expensive. It can be like $300, but again, one that you could use all over campus or just have at your rec center available for use. Yeah, that's all I got on that.
And then just a few more pieces of equipment. So just Amazon is a beautiful thing to find a lot of this stuff, but things as simple as card holders or adaptive gardening equipment, adaptive cooking equipment. These things are great. They can attach to literally anything, and it's going to provide just a strap on the person's hand. We've used them for arts and craft things. We've used them for fishing. We've actually put them on bike handles to help with that grip. Those are all pretty inexpensive things, but people might be hesitant to take certain classes because they might not have access to some of this equipment. So, having that available and promoting it might increase some of the individuals that you're seeing. There's a lot of like switch activated things out there. This is like a switch dice roller, so somebody can just press a button and it'll roll the dice for them so they don't have to worry about picking things up. We do a lot of adaptive gaming at the hospital. And then up at the top, we mentioned those active hands that kind of Velcro that person's hand onto whatever piece of equipment that they may be using. But again, just having some of this equipment is really going to, make people feel more comfortable doing things and being like, oh, I can access this class and I can do this just by offering a simple gripping aid, perhaps.
And I think the biggest takeaway, I want to give time for some questions too, but recreation isn't just sport. And for some people, just being able to access, a painting class could be really helpful. So are we really offering on campus more than just sports and really physical outlets? Do we have something that's a little bit more low-key? Can we start a gardening program and have a raised planting bed that people are working on every week? A volunteer program that people can come and give efforts for stuff like that. A card game group, something like that isn't just sport. So really kind of to challenge you all to continue to develop your programs and offer more than what we think of initially as recreation. But that's what we got. What questions do we have, if any? Comments, concerns, good jokes?
Can I clarify real quick? I just want to make sure I heard correctly. When you talked about insurance, because this is something I don't feel like I'm well informed on. I think I heard you say that a lot of the adaptive equipment we just saw there would not be deemed medically necessary and therefore is out of pocket.
Yes.
Correct.
You are correct.
There are I think we tend to see people that get injured on workers' comp. Some of that stuff tends to be paid for more there, but if it's just a regular Joe Schmo that unfortunately gets injured, yeah, that's coming out of pocket.
And just to repeat the question for people who are on Zoom, the question was, a confirmation on the fact that recreational equipment is not funded by insurance, so it comes out of pocket. And the answer to that was yes, that's true for most cases. Anybody else? Yeah.
As far as like maybe your strength equipment, for those of us that do work at the rec center, we're buying equipment to put in here to help. Do you have, in your opinion, like 3 or 5 pieces that you're like, yes, these pieces should definitely go in your gym that we should be looking out for when we're buying them?
I don't actually.
The question was just asking what like top 5 pieces of equipment to have like from a strength perspective from adaptations. Is that a good summary? Okay, cool. Go ahead.
I don't know what it's called, so maybe you can help me. But there's this piece of equipment, and it doubles as a hand crank and a foot pedal. So you can kind of pull the seat out, and they have the option to do either or. But I don't know what it's called.
That's a little, so from a strength perspective, we have the Peak Center at Craig, which would be an awesome, if you go on our website, you can access the like people who run that, and they're like exercise specialists for neurological conditions. So I just don't want to answer your question wrong, but I'll send you in the right direction. That her name's Buffy, if you find her online, that she runs the Peak Center, and she has like all that knowledge on names of equipment and how it's supposed to be used and how you can fund for it. So I hope that that's helpful. Go online.
There is a lot out there,
Yeah.
which is awesome. So
Yeah. Yeah, I would definitely, so we're a little, like, the Peak Center is connected to Craig, but not necessarily the same entity, so that is 100% the specialist in that realm. But yeah, reach out to Buffy for sure. I'll tell her that I said that so she doesn't just get whelmed in with a bunch of emails. Anything else? Okay, should we give you the microphone so I don't say it wrong?
So I've been thinking through the presentation about staff training, right? Because that came up earlier. And I feel like I've been exposed sometimes in sport and recreation to a narrative that folks are really inspired by people with disabilities doing sports, right? And I think that framing is often from the expectation that they're not capable. So then we're so excited that they are capable. I think about that through staff training lens. What are some core tenets you could give us to reframe that bias? So as we train our staff, we start to remove that narrative around people with disabilities.
That's actually really funny that you say that, because on our car ride up here, we were talking about that. I think one of the biggest things to do in a situation like that, and what we find ourselves doing a lot with patients when they're first learning something like this, is to just be real. Like, yeah, that rep sucked, or this is really hard, this is not going to be smooth. We try to really, we kind of get trained on it too, but framing a session or framing something with your staff too, to make sure that you're not setting somebody up for failure either. If it's their first time in an adaptive sport, you don't need to say, like, this is going to be the best thing ever and your life's going to be changed, but just to say, this is really hard, this is a brand new sport for you. Like, basketball on the court is different when you're able-bodied and when you're not, and that's the fact of it. So I think just really educating staff and people that you're training on that, whoever, like the keynote too, is saying, like, really just be transparent with people and be authentic. I think that's the best way to go about it. And not setting somebody up. We were just talking about how it's really frustrating sometimes to hear that, like, wow, you're so inspiring, or, oh my gosh, that's crazy that you can do that, which can come off in the wrong way. But yeah, I think I found the most buy-in from myself as someone who practices with patients, to just really be real with them and say, like, that was terrible, like, and that's okay. That's really hard. Like, you don't really look good right now doing that, and that's going to be a lot more kind of realistic for them, and it's real. I mean, they're humans. They are. We would say that to each other, right? So, just being authentic in that, and not in those moments. You don't have to consider the inspiring nature of it all, because it's not. They're just learning a sport the way that any other able-bodied student on campus would be. We're not telling our people picking up a Frisbee for the first time that they're inspiring either. So, unless you do it, and then you're very inspiring. Okay. I think we're at time to. We left our cards up here, so if you have further questions that we didn't have time for, Meg and I will also stick around for a second too, but thank you guys for your time.
Thank you.